Well, I will focus in mood disorders, which is really the field that I'm most comfortable with, and the area that I've been working on for the past, going on, I guess, a couple of decades now. Trying to answer the question as to whether, out of like 2 decades of neuroimaging research applied to depression and bipolar disorder, is anything panning out as actual markers that are already ready to help us clinically? Should I be able to advance those here? Okay, good. Excellent. Well, this is my new professional home. I've been since 2009 with the University of Texas in Houston, and this is our psychiatric hospital. It's called the UT Harris County Psychiatric Center. It is a 250-bed teaching hospital, which is really a key component of our department. And here's our new outpatient facility, to which we moved a couple of years ago, where our Center of Excellence on Mood Disorders is situated. So there is great excitement that with the improvement of neuroimaging tools, we really might be able to unravel the mechanisms and causes involved in neuropsychiatric disorders. Indeed, we can now look inside the black box. And Dr. Abhidargan showed us in a very elegant fashion the potential of the different modalities, from the anatomical techniques like high-resolution structural MRI, to functional studies with either functional MRI, SPECT, single photon emission computerized tomography, PET, positron emission tomography, as well as applications that allow us to study the chemistry of the brain as well. So I'll give you a brief overview of what's been done in mood disorders. Well, when that day comes, nobody's going to be happier than me. I mean, I'm living for the day when we can take a picture of somebody's brain and say, haha, I'm sure now this is schizophrenia or bipolar disorder. But I will submit here and hope to persuade you through my presentation that unfortunately, we are not there yet. So in the field of mood disorders, this is, by the way, a nice figure that I like from Yvette Schilin and her colleagues in St. Louis, essentially showing us this complex interface between a generic predisposition. We all know that mood disorders, they run in families, so there is a genetic component, even though we have not been able to pinpoint the specific genes. And also, those diseases have a lot to do with the stressors. Anybody who has taken care of a bipolar patient knows that when they are going through a divorce or change jobs or any type of like out of the ordinary excitement happens, that's usually when they're going to have a depressive episode or a manic episode. So those two interfaces resulting in depression, illustrated here. If this is a bipolar patient, obviously mania or mixed episodes. Then there is a lot of work out there conclusively showing that these diseases are related to subtle changes, particularly in frontolimbic portions of our brain. And I will elaborate more on that. And also, these conditions often happen in a comorbid fashion. Anxiety disorder, ADHD, as well as other medical problems. Like for some reason, these folks have more migraines, and they seem to be more obese. And so comorbidities are very important, psychiatrically and medically. We did a study a few years ago trying to answer the question as to whether a group of young adults with bipolar disorder, if we were to take MRIs of their brains, could we conclusively find evidence of like global pathology? And because the literature is a little questionable. I mean, if you look for wider sulci or enlarged ventricles, any signs of some global atrophy, there are many studies that did not find anything. The ones that did find tended to focus on more severely ill, multiple episode, elderly types of patients. So in this particular group, where the mean age was about 36 years old and matched to a really well-characterized, closely matched group of healthy controls, when we measured with a semi-automated technique the size of various important brain cell site, like for example the cingulate sulcus, superior, intermediate, and inferior frontal sulci. We essentially found evidence for wider sulci in the young adults with bipolar disorder across the board compared to healthy controls. And again, I mean, this is not something that one would see by and large by the naked eye. If you take an MRI of the brain of an adult with bipolar disorder and give it to a well-trained neuroradiologist, most likely it will be read as unremarkable normal MRI. If that is a very severely ill, chronic individual, primarily if it is like an elderly patient, you may find, in some instances, quite a few of what we call as hyper-intense lesions, which is, I mean, this is like a young patient, just one of those, but elderly folks with depression, in many instances, have quite a few of those periventricularly deep white matter. The relevance of those is not clearly established yet. Perhaps they disrupt fibers that interconnect these frontolimbic regions involved in regulation of mood. And again, I mean, this is very non-specific. Any type of psychiatric disorder like schizophrenia, OCD, or neurological problems, you will find such hyperintense lesions as well. So if one is looking for markers that hopefully will help us diagnose the disease, this is definitely not it. Trying to elaborate a little more on this notion that, well, perhaps these conditions where we have like pronounced mood swings and the highs of mania, the lows of depression alternating, there is a compelling story emerging that really says that, well, perhaps from the dysregulation of these specific brain circuits involved in modulation of our emotions, maybe those are key elements, key steps in the mechanism, the pathophysiology of a condition like bipolar disorder or unipolar depression. And the key areas here for us to look into, the anterior cingulate, other portions of the prefrontal cortex, and then middle temporal lobe, like the amygdala, which is, as you know, very much involved in fear response and emotional modulation. Hippocampus is another key area that's been shown to be abnormal with a multitude of technologies as it relates to mood disorders. A very brief summary of 2 decades of morphometric studies in the field of bipolar disorder will tell you that, well, by and large, there's a lot of inconsistency. I mean, few findings have been consistently replicated from one sample to the next. The one that's been probably most widely replicated, changes in the anterior cingulate that can be measured with the MRIs as a shrinkage. But it's just small, it's subtle, not definitely not anything that one could see by the naked eye. We essentially use specialized software that will measure the size of this structure, and then you average those numbers for patients and match it controls, and you end up seeing that there is a small percent difference as a group in the size of the anterior cingulate. Other studies have characterized that abnormality more closely to what is called the subgenual prefrontal cortex. It's an anterior and sort of like inferior to the genus of the corpus callosum, and I have some slides to show you that will follow. For the amygdala, some evidence for size abnormalities. In children and adolescents, it seems to be small to start. In adults, half of the studies have found it to be enlarged, the other half either not changed, and in some studies even is smaller. Hippocampus more clearly seems to be shrunk, and the studies that have shown that the stress has a lot to do with that. The striatum, the numbers go across the board. I mean, it's not a whole lot of consistency as to whether it might be enlarged, smaller, or just a normal size. When you look at the vermis of the cerebellum, some findings suggesting atrophy in that area. Well, and again, I mean, based on that first slide that I showed you, I believe there is consistent, and other studies that have shown that too, consistent evidence for some level of global pathology, which is in young patients not visible by the naked eye, in elderly, more severely ill folks. You may find some very non-specific signs of atrophy, like wider sulci, enlarged ventricles, not the types of changes that would allow us to look at the skin and say, well, there's like a 90% chance that this is a case of bipolar disorder. We are definitely not there yet with these particular modalities. Just to illustrate, we talked about anterior cingulate, and we did studies a few years back where we measured the size of the anterior cingulate with MRIs. And just an illustration here that untreated patients had lower values compared to healthy controls. Lithium, if anything, seemed to keep those values high. There's a lot of discussion as to what that could mean. I mean, could it be an indication of some neuroprotection that lithium may confer to folks that have responded to it, that have taken it regularly over the years? Then we extended those findings to a group of children and adolescents with bipolar disorder, where the anterior cingulate changes, the cingulate changes were even more extensive. And again, we're talking about some subtle shrinkage here in the case of this particular study. And this is a small sample size. We only had 16 patients and 21 healthy controls. But we did find not only changes in the anterior cingulate, but also extending to the posterior cingulate. We also did a study in unipolar depressed patients, and the interesting point, it's a sample like 31 patients matched to 31 healthy controls. And those are young adults, again, it's like late 30s, the mean ages for those two groups here. And what we found, which is of, I believe, great interest, is that both the left anterior cingulate as well as the right anterior cingulate, if you look at the volumes here in the depressed patients compared to remitted patients in healthy controls, you will find that depressed patients are lower than healthies, and the remitted patients sit somewhere in between. So suggesting some degree of alleviation of those changes as folks have their depression in remission, and more clearly shrinkage of that structure when they were depressed. We talked about the amygdala, and this will illustrate some of the problems that Dr. Abidaghan was alluding to in her presentation. If you look here, those are the size of the left amygdala in a sizable group of bipolar patients in healthy controls. And you see that in average, the bipolars had larger amygdala, but look at this big overlap here. So to think that a measure of the size of the amygdala would allow us to separate the patients from the controls with high specificity, high sensitivity, we are just really not there yet. There's also some hope that these techniques could be helpful to allow us to more closely monitor the course of treatment, or perhaps even predict the likelihood that somebody may respond to a treatment like lithium compared to other treatment modalities that we could recommend to bipolar patients. So this slide here illustrates, and again, this is the average representation. We had a group of adults with bipolar disorder and a matched group of healthy controls. We took MRIs of each individual subject, and we utilized software that allows us to average, produce a representation of the average brain of the patients, and then do the same for the healthy controls. And we subtract, and we color code, showing you areas that are statistically different once you correct for multiple comparisons. Because if you do a study like this, you're looking across, like voxels across the brain. So the statistics that you use really have to allow for corrections for all the comparisons you're making. What is of interest for us here? The group that we had of bipolars not on any treatment, I mean untreated bipolars, when we compare them to the healthy controls, blue is not statistically significant. So we could not find any areas of reduction, which is what we thought we would find, nor areas of increase, unlike what I'm going to show you here for the bipolars on lithium when contrasted with the healthy controls. Anything that is not blue here is statistically significant and showing higher gray matter in the group of patients compared to the group of healthy controls. And again, this is like lateral surface of the brain, right and left hemispheres, and this is the medial surface. So kind of like across the board, folks who have been on lithium for a while, that seems to really result in higher gray matter content. And folks knowing from preclinical studies that lithium interferes in favorable ways with important neurotrophins in the brain. So the story, the hypothesis is that, well, perhaps this demonstrates that somehow for folks who respond to it, lithium may be having neuroprotective properties. It does need to be investigated in longitudinal studies more specifically, and this was just a cross-sectional comparison. Switching gears to the functional studies. And again, I mean, we've had now probably 3 decades of functional studies of depression, and more recently, maybe a couple of decades of studies focusing on bipolar patients. Some consistent abnormalities do emerge. You will see like Rodman areas 24 or 25. This is like anterior cingulate, subgenual prefrontal cortex. And those have been shown reliably across different studies to have, but generally at baseline, they seem to have decreased metabolism, decreased neuronal activity. Compared to what you find for the amygdala, which seems to be hyper-responsive, both in unipolar depressed patients as well as bipolar individuals. It's not quite clear the time course of these changes. When do they take place and how do they relate to treatment response? Quite a few studies have looked at that, but I do not believe there are clear final answers yet. This is just illustration, a work from the late 90s that essentially shows a finding that's been really well characterized in many studies. We know that folks with depression have hyperfrontality. In this particular study, it was captured with SPECT and a blood flow tracer. And also, essentially showing that the more depressed these folks are, I mean, if you capture some negative symptoms, again, we usually talk about negative symptoms as related to psychosis, but the same scale that we capture that, if you apply to a depressed individual, they will, if they're very depressed, they will rank higher than that. So in this particular study, the measures of depression were really related to the blood flow to the prefrontal cortex, and that's not a big surprise. We know that depression comes with hyperfrontality, as well as schizophrenia and many different conditions. Wayne Dravitz and Helen Neighbor have been pioneers in this whole field. They started doing, going out on like 20 years, early FDG PET studies that characterized this reduced metabolism in the subgenual prefrontal cortex. This is a slide from actually a very famous, widely shown slide from Wayne Dravitz's work, as well as increased metabolism, glucose metabolism in the amygdala. So those were the 2 main changes that have emerged across several studies. My group published a study not too long ago from a PET 015 study that we had done, and in a group of depressed, untreated bipolar patients and healthy controls. And again, no big surprise here. I mean, what we found pretty much replicates, by and large, what had been shown in several prior studies, and changes that are primarily like in the cingulate and a few other from limbic areas. But I mean, the common, the most consistent thread here is really for anterior cingulate, as well as like the amygdala in many instances. Okay, so from Helen Mayberg's work, she's been treating depressed patients over a number of years already with different treatment modalities to try to see whether any of these markers will help us predict the treatment response. In this particular study, she essentially focused on the hypo or hypermetabolism of the rostral anterior cingulate. And so these folks were scanned before being treated with Prozac, fluoxetine, and then after a course of 6 weeks of fluoxetine. And what she found is that the folks who responded had higher metabolism in the rostral anterior cingulate compared to the folks who did not respond. Again, it's an elegant illustration of how these techniques can really be utilized as research tools and give us hope to really understand more about the mechanisms involved. I mean, one could ask, if I'm showing you here that perhaps hypermetabolism in the anterior cingulate, I mean, in this particular study was related to response to fluoxetine. I mean, is this enough to say that perhaps we should do a scan of a depressed individual before we treat them in the hope that that will guide our medication choice? Or and again, I mean, the first thing that I would like to submit to us here, this is a small patient sample. And the one medication was fluoxetine, and it's hard to essentially extrapolate that particular measure, that mere predicted response, better response to fluoxetine, that the same would be found with other treatment modalities. Helen, in subsequent work, actually showed that to some extent it does relate to response to cognitive behavioral therapy or other antidepressant measures. It is a costly technique where you are exposing folks to radioactivity. So one would essentially, one could submit, I would submit to you that, so if clinically the individual is depressed, then we pick any antidepressant that seems to be reasonable, like, for example, fluoxetine, based on the evidence available. It seems to be a very reasonable way to treat folks who are depressed. That the cost effectiveness of trying to pick this one marker that seems to be better replicated than the others, to propose that this ought to be done before treatment, I would submit that what they're going to learn up front is highly questionable. And if you consider the cost of doing it and the risk involved with the radiation exposure, which is, again, it's small, but obviously with radiation, the less the better. So the best radiation exposure is no exposure. There is a limit by the FDA as to how many you can do in a year. So when you try to integrate these things, and you think about the cost to the patient, the cost to the healthcare system, and the amount of data available, it is hard to make a compelling case that we ought to be doing it as it stands right now. And this is just an illustration for the prior work, where, again, this is kind of like Helen's and Wayne Dragon's too, and several others, my group included, and we found changes in this particular area here. And that's a biomarker of great interest in our field, there's no question about it, which needs to be further explored. The other biomarker that has gathered quite a bit of interest relates to measures of amygdala hyperactivation. And those are, by and large, fMRI studies, functional magnetic resonance imaging. And you give these folks tasks that are supposed to activate their emotions. In this particular case here, we had what was just a picture recognition type of paradigm. So you show them scary pictures and neutral pictures and happy pictures and sad pictures, and you contrast those. So essentially you are scanning their brain as they label the sad emotion, and you do that again when they label happy emotions and neutral emotions. And if you do that, in individuals with unipolar depression or bipolar disorder, you will see that their amygdala seems to be hyper-responsive. Many studies have shown that. This is just an illustration here of what we were just talking about. For, actually, yeah, on the left side and also on the right side. Well, so what is the problem with that particular biomarker? It's quite non-specific. Like if you look into like borderline personality disorder patient, yeah, the amygdala is hyper-responsive. If you look into folks suffering from an anxiety disorder, yeah. So thinking about a diagnostic value for that particular marker, it's just not specific enough. Then one could submit that, well, okay, what do the studies where folks treated these individuals with antidepressants or psychotherapy modalities? There is evidence out there that that hyper-responsiveness may actually come down closer to normal with treatment for folks who respond to treatment. But from those data to extrapolate and say that, well, let us do a scan that will cost about $1,000 a pop, and we do it before, and we do it afterwards. There is just not a compelling justification out there that this will result in us doing anything differently than what you do for a lot less cost and a lot less hardship to the patients. And that's why, I mean, I submit that this particular marker isn't ready either as it stands now. Okay, so if you think about neurochemical techniques, there is one called magnetic resonance spectroscopy, which is done with the same machine, the same magnet that allows us to do the anatomical MRIs. You just acquire the data in a different fashion, and you produce images also. You want to see the anatomy, but a different acquisition allows you to make some chemical determinations, and you can measure things like here N-acetyl aspartate, which is a very non-specific marker of neuronal viability, or inositol, which again is still of interest. This hypothesis that lithium depletes inositol in the brain has been around for a long time. So this is a tool that has been used to specifically test that hypothesis. You can measure things like glutamate. Depending on the acquisition, you could even measure GABA. So chemicals of great interest, and this has been used by many groups as a research tool in our field. When we talk to our colleagues in neurology, I mean, we can't help but get a little envious. I mean, it seems like for the pathologists that they work with, they've done enough work to show that certain types of like tumors and they do have beginning clinical applications that seem to be based on convincing data, where one could argue that doing an MRS in certain cases may actually help differentiate, do a differential diagnosis. But in our field of psychiatry, I'll tell you that, I mean, well, lower NAA is a very non-specific finding. You will find lower NAA in the dorsolateral prefrontal cortex in depressed individuals, in bipolar individuals, in schizophrenic individuals, and many other diseases. So it does not help us to really, as it stands right now, I mean, nobody has come up with a particular marker or a pattern of abnormalities in these markers that we could look and say, well, this is great. I mean, this is something we ought to be doing because it will help us a lot to separate these conditions. And as it stands now, it is still a research tool. We've done a study also with young bipolar patients and showed reduced levels in the dorsolateral prefrontal cortex. Others have looked at the hippocampus, also reduced NAA levels. Again, the areas where pathology has been identified, if you do an MRS and determine NAA levels, you know, like they're going to be lower. And one could find abnormalities in membrane markers, like, I mean, you can, one of those chemicals, the peaks that I showed you before, is for what we call like choline-containing molecules, I mean, which have to do with like membrane processes, and that's sort of where we are with that. Well, this is another modality that I worked in studies like this in the late 90s, and I had great hope that the type of MRS that allows us to measure the concentration of lithium in the brain could guide, could inform our clinical decisions. And this has, by and large, been put aside by many groups that have looked at it, including ours. Part of that probably has to do with the resolution. Lithium, at the doses we can give to our patients safely, can be detected in the brain, and one can even produce kind of like an imaging mapping. But you end up having to measure that across a big chunk of brain tissue, and you end up averaging those values. So the resolution isn't high enough that one could really focus on smaller areas of the brain. Well, but even if one could do that, then I guess the bar here has to do with, okay, so let us study the distribution of lithium in the brains of patients that respond and patients who did not respond. The next bar would be, so we have like this great looking figures, and it is, indeed a great technique, but will that really make a difference? Unless we can really demonstrate that early in the process, any of those measures will, if they will give us the likelihood that somebody will tolerate lithium well, respond to lithium well, in a reliable fashion, I could see that eventually becoming a tool that all of us should be utilizing. Otherwise, it's a very expensive procedure, which for now belongs as a research tool. And so here is patient's brain, and the way that we did this, a phantom with a known concentration of lithium, and we had to acquire a signal for like a whole chunk of brain, and then you end up with two peaks, one from the patient brain, the other from the phantom, and you do a proportion, and that's how you can quantitate the lithium in certain brain areas. Again, it caused some enthusiasm, and it's interesting research too. It's something that I consider has not panned out. Well, Anissa Abdargan has told us extensively about the potential of the radio tracer imaging, and those are great tools for us to learn about the mechanisms in pathophysiology. One can map the dopaminergic system, serotonergic system, and several studies are ongoing and have been ongoing for a while, with really interesting findings, and again, the trouble is they are by and large subtle, not specific enough. So what Anissa showed you for the field of schizophrenia, I'd say that in depression is even earlier. If in the field of schizophrenia we are not ready as far as those specific biomarkers, I would agree with that. As far as depression and bipolar disorder, we are even behind. This is Wayne Dravitt's work, and the particular tracer here is to map serotonin 1A receptors, and this was a PET study. Well, Anissa told us about rapid pride and ways to map the dopaminergic system. Okay, well, so what I also want to leave you with the following prospect. So if neuroimaging enough isn't panning out as something that can generate markers that can inform our clinical decision, I do have great hope that as we begin to combine the neuroimaging markers with neurocognitive markers, specific markers that we could derive from neuropsychology, and then begin to combine those with knowledge from genetics, perhaps a combination of techniques and approaches might allow us to get more sensitivity and specificity, and come up with panels that may help us, that may be of some clinical utility, which is definitely the final goal here. And again, this is preliminary work that we published 3 years ago, where we focused on a gene called the BDNF gene, brain-derived neurotrophic factor. This is an important neurotrophic in the brain. And this is a known polymorphism, a variant in that gene that is called Fall66 map. And this particular polymorphism here has been shown in a multitude of studies to relate to measures of brain anatomy, brain function, with a multitude of techniques. So knowing that the bipolar patients, I mean, in average, I mean, that they have these changes that we talked about here, we wanted to see whether some of those may not be determined by the specific generic variation. And it's preliminary work. I mean, if you look here, the sample isn't large, but what we were excited about, and again, up here we have this is anterior cingulate, and I'm sorry, up is left anterior cingulate, and down is right anterior cingulate. And we measure, I mean, those are volumes, and we had, in red here, those are patients that had the MET allele, the methionine allele. Those are patients that did not have the MET allele, and healthy controls with the MET allele, without the MET allele. So no statistical difference here for the healthy controls with and without the MET allele, but in patients, that seems to have an important effect for to try to explain, in explaining those lower volumes for the anterior cingulate that we talked about. Same pattern on the other side. So again, I mean, this needs a lot more replication. And I will be, I'll tell you also, there's some early data, it's not ready to be published yet, we tripled the size of the sample. And we were very hopeful that if the anterior cingulate small shrinkage is a marker that we believe in, and that we think that the genetics might be affecting this, so we really expected that once we looked at the Vol 66 MET polymorphism as related to the size of the anterior cingulate in a larger group of bipolar patients, that finding would become stronger. I will tell you, I mean, the first pass analysis, I didn't have it to share with you here today. It's actually very disappointing. I mean, the finding seems to have disappeared. So showing the complexity of these generic inheritance in these really complex conditions that we diagnose and treat. So to conclude my talk today, I will tell you that I really believe that this is a wonderful phase, a wonderful time for us to be practicing psychiatrists. I really believe that within a 10-year time frame, we will know a lot more than we know today about what causes these diseases, about early markers. I really believe that we are going to have specific markers that will help us diagnose, monitor the course of treatment, perhaps help us predict the chances that a patient may respond more to a certain treatment modality than the other. But for now, in the field, in my particular area here of mood disorders, and those are still research tools. The burden of essentially demonstrating that any of these markers is ready to be more widely applied in clinical settings, that this is going to make a difference clinically, that it's going to be cost effective. That's a high bar, and it's just not there. And one could debate on how conservative or how forward we want to be, and I do believe there is a very fine line here. Well, our field is already plagued with lots of stigma and not a whole lot of respectability out there. We see that in the last thing we want to do is to pick things that aren't ready, jump on them. I don't think that's going to help our cause. That's not going to help our patient's cause. And that's why I would here propose that we ought to be more conservative and wait till there is enough robust data to really, for us to be able to propose, that any of these markers have to be applied routinely and more systematically in any of these patient groups. I have great hope that by applying these techniques like in longitudinal studies, focusing on early onset, first episode patients, high risk offspring, and this is really where I believe the money is. I think of psychiatric disorders a little bit like I think of cancer, where, well, just by virtue of how much you know about the brain's plasticity and ability to, I guess, regenerate a little bit in certain areas. It's not a whole lot. So when we diagnose these conditions after multiple episodes and once they've already taken a hold of somebody's brain, I mean, I do believe that it's kind of like catching up. We can help them a little, but we're not going to make a big difference. The best hope is really once we understand enough about the early vulnerability and we can figure out what are the right interventions and utilize biomarkers that will help us monitor that, that's really how I strongly feel we can conquer these conditions and make a big difference in our patients' lives. And I will finish here and I'll take any questions. Thank you so much.
Okay, I think we only have time for one question. Remember, please go up to the microphone to ask your question.
A question over there?
Remember, please use the microphone. Please use the microphone, please.
For many years, psychiatry has been dichotomized between the difference between the unipolar spectrum disorder, the bipolar spectrum disorders. In your opinion, in the next 10, 20 years, is there going to be a biological substratum that might differentiate either from the other, or the possibilities are that they share the same pathophysiology?
That's a great question. Studies keep showing more and more that these diseases are more alike than dissimilar. And if you think of brain circuits that modulate our emotions, I do believe that these diseases probably will come from different levels of involvement in some of those same brain regions and circuits, and some of the same genes that make comfort vulnerability or comfort protection will be at play, not only in bipolar and unipolar disorder, but autism, schizophrenia, and so we need to learn a lot more about the vulnerability factors and the mechanisms involved, and I strongly believe that we will find a lot more commonalities than differences.
Thank you very much.
Okay. Thank you very much for a great talk.